Good morning, everyone. Today I'm here to talk on the impact of contrast sensitivity on driving behaviors in individuals with moderate to severe glaucoma. Contrast sensitivity is a key element of visual function and greatly influences daily activities like driving. Glaucoma often results in a gradual loss of peripheral vision and can impair contrast sensitivity. At present, there are 80 million individuals with glaucoma worldwide, and these numbers are plentiful to infer that probability of on-road drivers having this disease is high. Traditional contrast assessment tests like Pelliropsin measures only central contrast sensitivity and are subject to various limitations. Meanwhile, Spaeth-Richman contrast sensitivity test is an internet-based test which overcomes these drawbacks and measures both central and peripheral contrast sensitivity. The objectives of this current study are to explore the relationship between central as well as peripheral contrast sensitivity with driving behaviors in moderate to severe glaucoma patients. It is a cross-sectional analytical study which included 45 patients with moderate to severe glaucoma who are currently driving. The inclusion criteria was age more than 40 years either gender and best corrected visual acuity of 6/12 or better. Patients with other ocular diseases were excluded and complete ocular examination was done. Spaeth-Richman contrast sensitivity test is a computer-based test in which the patient is instructed to fixate on the central area of the testing screen and identify which of the areas appear different. Vertical square wave gratings appear for 0.3 seconds in one of the tested 5 areas. The range of contrast tested is 0 to 2.35 log units, which decreases approximately by 0.15 log units between the levels. It measures contrast in both all the central and peripheral areas with maximum score being 100. This is a representative case of moderate glaucoma. The left eye shows inferior arcuate defect with total spark score of 66 and right eye shows hemiarcuate defect with paracentral scotoma and spark score of 60. The central image shows binocular estimate visual field acuity test which has efficiency score of 109. This second is a representative case of severe glaucoma showing arcuate defects in both the eyes and spark score of 57 in right eye and 51 in left eye. The results were the average age was 61.76 years with male predominance and most of the patients having primary open angle glaucoma. Contrast sensitivity in better eye was 2.8 with standard deviation of 0.24 and in worse eye was 1.95 with standard deviation of 0.27. The sparks in better eye was 66.58 with standard deviation of 9 and worse eye was 58.51 standard deviation of 9.67. The mean driving difficulty score measured by the driving habits questionnaire was 61.8. Lower score indicates greater difficulty. Mean driving space score was 2.98. Meanwhile, driving dependency score was 1.96. Now on correlation of contrast with scores, dependency scores showed negative correlation with sparks. Driving difficulty scores and space scores showed positive correlations with sparks. Now, literature so far has only looked into the effect of contrast sensitivity loss on overall driving performance in glaucoma patients and have concluded that patients with poor contrast had poor driving performances on driving circuits. The current study shows that individuals with poor contrast threshold in peripheral quadrants, especially upper right and lower right, in their worse eyes, experience more driving difficulties while driving in difficult situations and are more dependent on others for mobility. The limitations of this study are small sample size and predominance of male participants, and to enhance the credibility of our findings, a subsequent study employing objective assessments like driving stimulators can be used. To conclude, patients with glaucoma face many difficulties while driving, have lesser driving space and are more dependent on others for mobility. This study reinforces the importance of incorporating contrast sensitivity assessment into overall evaluation of driving fitness, especially in glaucoma patients. Thank you.
Thank you. Meanwhile, Dr. Sardana, you can set up your talk here. So how do you differentiate just contrast versus contrast and visual fields or glare sensitivity, or the other visual functions in these cases?
The visual field testing was done with the help of Visual Field 24-2. Binocular field testing, which kind of simulates the patient's perspective, was done with the help of binocular estimate visual field testing, which tests supra-threshold points 120 in the range of 120 degrees horizontally and 50 degrees vertically. And for contrast sensitivity, we use traditional method like Pelliropsin, which only focuses on the central contrast sensitivity assessment. But the newer advances like Spaeth-Richmond contrast sensitivity test includes testing of peripheral as well as central area of contrast assessment around 30 degree horizontally and 23.5 degrees vertically.
True, because in the real world scenario, that's
Is
going to matter
that
more than just the central.
more than just central.
What would be your cutoff sparks level at which you would advise the patient not to drive at night?
So as per the normative data for these sparks, usually more than 70 sparks is considered normal.